Hello and welcome. My name is Sal Robledo, and I am a member of the Cottage Health and Public Health. Thank you for being here tonight at this event on how to protect yourself and your family against cancer. Tonight's presentations and conversations will provide valuable resources and information to prevent cancer and help with early detection, which could save your life. The slides this evening will be displayed in Spanish. A link, if you'd like, a link to the slides in English has been posted in the chat box. Tonight's event is hosted by the Ridley-Tree Cancer Center and Cottage Health. You will hear from medical and community experts who will define what a screening is and will talk about cancer screenings, colon, breast, and other cancer screenings. As this webinar aims to keep you and your family safe from cancer, we will discuss how and one of the best ways to prevent and detect cancer is to get screened. In addition to getting screened for cancer, eating healthy, getting plenty of exercise, and maintaining a good body weight are important to prevent cancer. To encourage you to eat a healthy diet, we will send you a free cookbook with healthy recipes. This copy is bilingual. During the presentation, we ask you to mute your microphones. Please feel free to add questions or comments in the chat box. We'll answer these questions from the chat box at the end of the presentation. Our presenters this evening will include Dr. Thomas Aguirre, gastroenterologist, Dr. Winnie Leon, breast radiologist, and Captain Christopher Martinez, colorectal cancer survivor and fire captain for the Lompoc City Fire Department. At this time, I'd like to hand this over to Dr. Aguirre, who will begin with a brief introduction of himself.
Gracias, Sal.
Thank you, Sal.
So, mi nombre es Dr. Tomás
My
Aguirre.
name is Dr. Thomas Aguirre.
Mi especialidad es
My specialty
gastroenterólogo.
is gastroenterology.
And tengo 18 años de
I
experiencia.
have 18 years experience.
And the rest of my talk will be in English. And I'll take the next slide. So what is cancer screening? Well, cancer screening is any test or exam that can be performed before a person has symptoms of cancer. Next slide. The reason it's important to detect a cancer before a person would have symptoms is that increases a person's ability to cure the cancer or survive longer. Next slide. So we're going to talk specifically about colon cancer screening. We're going to talk about the where, what, who, when, how, and why of colorectal cancer screening. Next slide. So this is the where, parts of the colon. When you eat or ingest food, it goes obviously through your mouth into your swallowing tube, into the stomach that grinds up the food, and then into the small intestine, which absorbs food. The last part of the digestive system is the colon, which is depicted here, which basically packages and absorbs salt and water prior to allowing the defecation process to occur. Next slide. So what are the symptoms of colon cancer? Well, they're related to the colon, obviously. And some of them can be constipation, diarrhea, blood in the stool, change in the caliber of stool, a low blood count, abdominal pain, fatigue and weakness, weight loss as well. Not all these are the cause of colon cancer. Colon cancer isn't the cause of all these things, but there are things that these are things that you should see your doctor about. Next slide. This is the what of colon cancer. So this is a cartoon depicting colon cancer. Basically, there are 4 stages of colon cancer, and stage 0, which is on the top there, shows a polyp or abnormal growth of the colon. It just looks like a little bump. Stages 1 through 4 are areas where that polyp or abnormal growth has genetically broken down and begins to invade the wall of the colon, and in stage 4 can spread to other organs. This gives gastroenterologists a unique opportunity to really prevent stage 1, 2, 3, or 4 by removing the polyp before it genetically breaks down. Next slide. The next slide is a little cartoon showing a colonoscopist removing an abnormal growth. Now, this is an abnormal growth that we call a polyp that has yet to genetically break down and yet to invade and become a true cancer. So again, colonoscopy gives us a very unique way of preventing a cancer from even occurring, not necessarily even catching it early, but really preventing it. Next slide. So here's again with the what of colorectal cancer screening. So it's the 2nd leading cause of death from cancer in the United States. About 149,500 adults are expected to be diagnosed in this year, 2021. Screening, we know that screening for colorectal cancer reduces the occurrence and death from the disease. Unfortunately, only about 68 or 69% of age-eligible adults are having up to date with their colon cancer screening. Again, screening can detect disease early and also can prevent cancer, again, by removing these polyps. Next slide. So next slide here. Oh, next slide. There we go. Sorry. You go back. Sorry. Back to the one side. So who is at risk? People who have a family history, meaning a mom, dad, brother, or sister, physical inactivity, people who are overweight or obese, high consumption of red and or processed meats, people who smoke, moderate to heavy alcohol consumption, and people with a chronic illness called inflammatory bowel disease. And these are people that may need colon cancer screening more aggressively and at an earlier age. Next slide. So I'd like to spend a little time with this slide, a little extra time. The rates of colorectal cancer screening in young adults under the age of 55 has been increasing. And in fact, if you take someone who's born in the 1990s, they have a double the lifetime risk of colon cancer and quadruple the risk of rectal cancer compared to adults born in the 1950s. Approximately 20% of all colorectal cancers in the United States are diagnosed those younger than age 55. Patients diagnosed with colorectal cancer before the age of 55 are 58% more likely to be diagnosed with more advanced disease. Again, we talked about those stages, so they'd be further along on those stages. Next slide. So the colorectal cancer incidence in adults over 45 years old is almost the same as those over the age of 50. And about 1 in every 10 new cases of colorectal cancer occurs in patients under the age of 50. And so there is some benefit to doing colorectal cancer screening in patients younger than age 50. And so new recommendations have been over the age of 45 is the time that you would start doing colorectal cancer screening. And we'll talk about the different types here in a moment. When someone is between the age of 76 and 85, then that should be between them and their doctor, whether they should continue colorectal cancer screening and the benefits and risks of that. And here's a cartoon. Next slide, please. And here's a little cartoon showing the recommendations for the age appropriate time to do colorectal cancer screening. So again, the first cartoon shows at age 45 to 75 would be the ideal time. Again, age 5 being the start of it. Between age 76 and 85, it's really between you and your doctor, and it depends on a person's health, what the benefit of colorectal cancer screening would be. Over 85, it's very unlikely that colorectal cancer screening would be of any benefit. Next slide. So the how. So what are the things that we do to screen for colorectal cancer? Well, they're broken down into stool-based and visual-based tests. The stool-based tests include occult blood or GWAG testing, where we don't see blood in the stool, but we can do a chemical test on the stool to see if there is occult blood. There's also what we call a FIT test that we can do every year for that. A FIT test is just a more sophisticated test to look for blood in the stool. At the end of this program, we're going to have some opportunities for you to participate in FIT testing, which again tests the stool in a more sophisticated way for blood. And then there's a multi-targeted stool DNA test, which is recommended to be done every 3 years, and those are available through your doctor. If any of those tests are positive, then we would move on to the standard, the gold standard of colorectal cancer screening, which is colonoscopy. Colonoscopy has the advantage of being able to identify polyps and remove them at the same time. Colonoscopy is a procedure that is done either at an outpatient hospital or in an outpatient ambulatory setting. And it includes a bowel purge, which happens usually the day before the procedure. The day of the procedure, sedation is used to make the person comfortable. And then a tube, which is usually no thicker than my index finger, with a light and a camera at the end of it, is inserted into the rectal area, and the whole entire colon is examined, taking about 15 to 30 minutes, depending on what is found. Again, if polyps or abnormal growths are identified, in general, they can be removed during that colonoscopy. If the colonoscopy is completely normal and the person has no family history, meaning mom, dad, or brother or sister with colon cancer, then the recommendation is to have that colonoscopy every 10 years. Again, colonoscopy represents the gold standard of colorectal cancer screening. A flexible sigmoidoscopy, which looks at only 1/3 of the colon, can also be performed as a screening test, and that would be recommended every 5 years. A CT scan looking at the colon can also be performed every 5 years. Again, with those tests, if polyps are found, colonoscopy would be recommended. Next slide. Well, here comes the reason why we would do a procedure for screening for colon cancer, and why I did my colonoscopy just 5 days after I was eligible, after I had my birthday. Here's a picture of my 3 wonderful sons and my precious wife. And that's the reason we do any type of screening for cancers, is for the people that we love. They want us to be around, we want to be around them, and we hopefully have many, many years to enjoy. And that's why we really strongly recommend colorectal cancer screening. Let's go to the next slide. And we'll take a little time here. So because of COVID, colorectal cancer screening has been quite affected. There's a 90% drop between last year in March and mid-April of colonoscopies that were done. And this is estimated about 1.7 million colonoscopies were missed, and this is throughout the United States, from March of last year to June of 2020. And again, this is related to the pandemic, the COVID pandemic. So this could lead to about 18,000 missed or delayed diagnoses of colorectal cancer screening. And this is from mid-March, early June of last year. And that could lead to 4,500 excess deaths from colorectal cancer screening over the next decade. So that's why it's important to really push colorectal cancer screening. Next slide. So let's just summarize. We go the where of colorectal cancer screening. Colon is the last part of our digestive system. And we know that the symptoms of which are related to the colon: change in bowel habits, constipation, change in diameter of stool, blood in the stool, low blood count, which we would call anemia, fatigue, weight loss. Those are all things that could, not always, but can represent colon cancer. Will lead us to see our doctor. The what of colon cancer? Well, we know almost all colon cancers start out as these colon polyps, which gives us a chance to remove them prior to them becoming a cancer. Well, we're recommending everyone the age of 45, and those at risk factors that we described earlier may need it younger and more frequently. The when is age 45 to 75 for average risk patients. How, we have stool tests that we talked about. We have the colonoscopy, which is a gold standard, and the other visual tests. And the why, well, we do it for those that we care about. That's really the reason to do any type of screening and to take care of your health. All right, I have the pleasure of introducing Dr. Leung.
Thank you, Dr. Aguirre, and thank you everyone for joining us tonight. I am Winifred Leung, and I'm a radiologist who specializes in breast imaging. I've been practicing in the Santa Barbara community for about 11 years, and I'm currently part of Ridley-Tree Cancer Center at Sansom Clinic. Next slide. Tonight, I'm going to talk about breast cancer screening primarily, but I'm also going to touch on cervical, lung, prostate, and skin cancer, as well as when we might want to talk to a genetic counselor. Next slide. Breast cancer is an abnormal growth of cells within the glands that produce or carry milk. Symptoms are listed here, with the most common being a breast lump, change in breast shape, or nipple discharge. In these cases, we would not be screening for disease, which is looking for disease in healthy patients, as Dr. Aguirre mentioned, but we would be trying to make the diagnosis to make sure that there isn't breast cancer. Women with symptoms on this list are not coming for screening, but are coming in for a diagnostic exam, which would include mammography with or without ultrasound, MRI, and possibly a biopsy. Next slide. Unfortunately, breast cancer is very common, with 1 in 8 women developing breast cancer in her lifetime. The fortunate thing about this, the silver lining, is that because it is so common and affects so many women, we really have done a lot of research and know exactly what to do with breast cancer. Some risk factors we can control, including decreasing alcohol intake or maintaining a healthy diet and weight, avoiding long-term hormone replacement therapy if you don't need it. There are other factors, though, that we can't control, and these include our menstrual history or genetic makeup. That being said, the vast majority of breast cancers, 85%, occur in women with no family history. They are what we call sporadic, and only 5% are attributed to genetic mutations that we know about, such as the now famous BRCA1 or BRCA2 gene. Next slide. Mammography is an X-ray of the breast, and it is the gold standard that we use to find breast cancer. Nowadays, we actually use 3D mammography, or what is known as tomosynthesis. You can kind of think of this as a higher resolution mammogram. The radiation dose from a mammogram and from tomosynthesis is very, very small. We measure it in millisieverts, and a mammogram dosage is about 3 millisieverts. That's equivalent to about 7 weeks of normal background living, the radiation that we get from our ambient environment. Next slide. So the when of breast cancer screening is every woman starting at age 40 who's at average risk. If there are no new problems, then it should be repeated every single year. Next slide. So kind of as an analogy to what Dr. Geary was talking about earlier with colon cancer screening, early detection is key. We want to find cancers before they show up as a symptom, such as a breast lump. The average size of a breast lump that can be felt by a woman or her primary care provider is usually about 1.5 inches. The average size of a breast cancer that can be found on mammography is half that size at 3/4 of an inch. And the average size of a breast cancer that can be found on a mammogram that has a prior comparison mammogram is 1/3 of that size at 1/2 inch. An often credited number is that mammography has dropped breast cancer deaths by 1/3. On the other hand, skipping a mammogram can miss up to 30% of cancers. This is particularly important in the year 2021 as we come out of the pandemic, where a lot of screening for cancer has been delayed. Breast cancer screening across the country has decreased by at least 50%, and it still has not returned back to normal. So there are backlogs of patients and delays in scheduling. So if you've not had your yearly mammogram, please remember to schedule it soon. Breast cancer detected at an early stage or a small size do very well, with a 5-year survival rate of close to 100%. What I tell my women patients often with an early stage breast cancer is that this will not shorten your life. Next slide. After a screening mammogram appointment, which usually only takes about 15 minutes in the radiology department, the woman is free to go home or to go back to work. She's notified several days later as to whether her mammogram is normal or if more imaging is needed. About 10% of women are asked to come back for more imaging in the form of another mammogram view or an ultrasound to clarify what's being seen. I get a lot of anxious women who are very worried when they get called back for additional imaging. But please keep in mind that of these 10 women, 6 women will be reassured that their exams are normal. 2 women out of the 100 may be asked to come back for short-term imaging follow-up, usually in 6 months. And less than 2 will be recommended to have a biopsy. So the point is, if you are in the 10% that get called back for additional imaging, or even if you're in the less than 2% that get recommended for a needle biopsy, it does not mean that you have breast cancer. Next slide. Let's talk about risk for a minute. I mentioned that average risk women should start screening every year at age 40. How do we determine if someone is high risk? When you come in for your mammogram appointment, we ask you a series of questions, and these answers are put into a calculator similar to what you see here. You can see that we ask if you've had a history of breast cancer, the age of your first menstrual cycle, how many first-degree relatives you have with breast cancer, whether or not you've had a breast biopsy, whether or not atypia was discovered on that biopsy. All of these factors go into assessing the risk, which translates to a number. 12% is the average lifetime risk for average risk women. If the calculated lifetime risk exceeds 20%, then you are placed in a high risk category. Next slide. Other high risk situations besides having a lifetime risk greater than 20% would be if you have had a known genetic mutation diagnosed through genetic testing, such as BRCA1 or BRCA2. If you've had a history of radiation to the chest, usually for lymphoma at an early age before age 30. If you've had a history of biopsy with atypical cells, these high-risk women are recommended to have mammography with an annual MRI. Women with a history of breast cancer before age 50, or women who have had a history of breast cancer at any age with dense breast tissue on mammography are also recommended to have an MRI every year at the time of their mammogram. Next slide. I'm going to go on to screening for other cancers. The cervix is the part of a woman's body between the uterus and the vagina. Like breast cancer, cervical cancer can be very common, and if found early, it is very treatable. The recommendations I list here are a bit approximate in that different societies have different guidelines on screening age and frequency. But loosely, several societies, including the American College of OBGYN, recommend screening starting at age 21 to approximately 65. Screening is performed by a gynecologist or a primary care physician through a speculum exam where cervix cells are sampled for either a pap smear or an HPV test. The method for either test is the same, but depending on whether you get a pap smear or an HPV test, then testing is repeated either every 3 years or 5 years. The prostate is a gland in a man's body between the bladder and the rectum. Just like breast cancer is the second most common cancer in women with increasing frequency as we age, prostate cancer is the second most common cancer in men with increasing frequency as men age. Just like breast cancer, screening tests exist. Screening regimens, again, are a little different depending on which society you ask, but generally a conservative guideline is to be tested between ages 55 and 69 with a blood test called PSA, which stands for prostate-specific antigen. Depending on your PSA level, you may have another test in 2 to 4 years if the PSA is low, or if the PSA is intermediate, you might have it in 1 to 2 years. If the PSA is high, you may have additional testing recommended, which may include radiology imaging of the prostate gland. Skin cancer is of great interest, not only because it's very common, but because we live in a sunny climate here in Santa Barbara. There are actually no consensus guidelines from any society regarding skin cancer screening. That's because most skin cancers, the common types, are non-melanomatous, such as basal cell or squamous cell carcinomas. These are not deadly, and they're usually found by the patient just looking at his or her skin, or found by the primary care physician. That being said, if you find a new skin lesion, you should tell your doctor. Also, if you have a family history of melanoma, which is the deadly but rare kind of skin cancer, you should be seen by a dermatologist. People with multiple atypical moles should also be seen by a dermatologist. Finally, lung cancer screening is performed with a low radiation dose CT of the chest. This is recommended for people ages 50 to 80 who are currently smoking or have quit smoking in the last 15 years with a 20 pack year history of smoking. And the way that pack year history works is a little bit tricky, but basically, if someone were to have smoked 1 pack a day for 20 years, then that's 20 pack years. If someone else smoked half a pack a day for 40 years, then that's also 20 pack years. And he or she would be eligible for screening with low dose chest CT every year. Next slide. Finally, we have a really valuable resource in our community with genetic counselors at Ridley-Tree Cancer Center. It's actually very rare to have so much genetic counseling talent in a city as small as ours. And I'm often asked by my breast cancer patients whether or not they need genetic testing. And I refer a lot of my patients to these genetic counselors. So if you answer yes to any of the following questions, you may be a candidate to see our genetic counselors. If you or a family member has been diagnosed with cancer before age 50, if you or a family member has been diagnosed with more than one type of cancer, if you or a family member has had a rare cancer, such as ovarian cancer, if the same type of cancer has been diagnosed in 2 or more relatives, if there's a known hereditary syndrome in your family, or if your family history causes you to worry about you or your children, then that might be a good indication to see our genetic counselors. Now, without further ado, I would like to introduce Mr. Christopher Martinez, who is a colorectal cancer survivor treated in our community and also a captain at the Lompoc City Fire Department. Thank you, Mr. Martinez.
Thank you, doctor. Buenas noches. Mi nombre es Christopher Martinez. Soy un bombero local. Nací y crecí en Santa Barbara.
I am a local fireman. I was
Esta noche
raised and I was born
voy a
in the city of
compartir
Lompoc. I am going to be sharing with you the following information.
Esta noche voy a compartir mi experiencia
This evening, I'm going to talk to
de
you about
cuando
my
me
experience
diagnosticaron con
about when
cáncer
I
de
was
colon.
diagnosed
colon.
with cancer,
Disculpen,
colorectal cancer.
disculpen, mi español no
I
es muy bueno,
apologize because my Spanish is not so good
debido que mi historia todavía es muy emocional para mí.
because this subject is so emotional still for me.
La voy a compartir a través de un intérprete.
So I am going to start sharing this through our interpreter.
So I was diagnosed with cancer at 43 years old. I think it's important to mention that I have 0 family history. I guess they say they're risk factors. I've never been overweight. I work out 5 to 6 times a week. I actually used to be a professional athlete. I was showing 0 symptoms. And another important thing to say is my wife is actually a nurse at Cottage. And I get annual physical once a year through her job, through her health plan, and an annual physical through my job. So I actually get 2 annual physicals a year, which I'll touch on later. How was I diagnosed? I was diagnosed through my annual physical and my blood labs. I actually came in anemic. And I think Dr. Aguilar talked about some of those things. I came out anemic, and the doctor that was doing the physical recommended me to talk to my doctor at the time. So I talked to my primary care doctor, Dr. Frainer, and he actually thought it was a mistake. Remember, I get 2 physicals a year, been doing that for over 10 years. And he had just saw me 8 months ago, and all of my labs were within normal range. So he actually had no initial concern, and nor did I. Then he reran my labs, and I was anemic. He actually did a stool sample, which Dr. Aguilar also talked about, and I did have blood in my stool, but I didn't have the fatigue. I didn't have the pain. I didn't have the weight loss. I didn't have, my stool was dark because I'm actually have like a lot of blueberries and kales in the morning. I'm mostly plant-based diet. So as soon as they found out I was anemic and I had blood in my stool, I got an emergency colonoscopy, and that colonoscopy presented that I did have 2 tumors. And I was rushed into emergency surgery 5 days later. Did emergency surgery at Cottage. Dr. Conway did it. And when he was actually reviewing my labs and kind of going through the pre-surgery thing, he mentioned 8 months ago, you look perfect, and now you're here. He had a lot of concern, and I think it's very important that everyone does get this preventative motion, because you don't want to be in my situation where you're all of a sudden in a hurry and at a big fight. So I did emergency surgeries 5 days later. I did 6 months of high dose chemo, which was horrendous. My recovery then lasted 3 or 4 months after that. And then I returned to work, where I'm still a firefighter today in Lompoc. My story actually is highlighted by my advocacy towards all of you to get checked out. I actually tell my friends and my family, all of my colleagues in the fire service, get your labs done in the physical at a minimum once a year. That's what saves my life. I know that the term for colonoscopies is 45 years old. I got diagnosed at 43 with zero family history. And that's something that has changed my life, because I'm still actually having a cancer fight today with a lot of fatigue, a lot of fogginess still post chemo. I still reflect on the cancer story, and it all goes back to preventative for my annual physical and my blood labs. If you are having trouble looking for a doctor or get your annual physical or getting your labs drawn, I know there's resources here that you can access to find the best way to get that done. Also, Dr. Aguirre talked about the stool sample. I think the FIT test, he called it. That is what really found the blood in my stool that kind of prompted all this to get done and saved my life. Thank you for your time. I look forward to answering any questions you might have. I'm going to now pass the presentation on to our host, Sal.
Thank you, Dr. Aguirre. Thank you, Dr. Leon. Thank you, Captain Martinez, for the valuable information, for sharing your story tonight with us. Now, I would like to give everyone the opportunity to ask questions of our presenters. Please, if you could use the feature of raise your hand so I can recognize that you have a question, and you can just ask your question live. If you don't have the raise your hand feature, write your question in the chat and I can read your question out loud. So let's wait a few moments to see if anyone has a question. We have a comment that says, thank you for sharing. Well, I'm going to start with a question. If I wanted to have the test, how do I get started? What is a way to start the process?
Which type of testing are you asking about, Sal?
Colorectal.
I can answer the question. It sounds so there's a couple different things you could do. So we have the free fit kit that you can get at the end of this event, and we can send it to you. But as Dr. Aguirre mentioned, the gold standard for colon cancer testing is the colonoscopy. So I would ask if you had insurance or a way to get that. And if you need help with figuring out your insurance or applying for insurance where you could get a colonoscopy, my phone number will be at the end. I am Lisa Weinbrenner with the Ridley-Tree Cancer Center, and I can help you get the insurance or navigate the way to get scheduled. I'm just going to give you my phone number out loud because it's on the slide, but I'll give it to you anyway. 805-879-5678. So you can call me and we can talk about how you can get a colonoscopy, but you can also fill in the form at the end of this event that will send you the free fit kit if that's what you'd rather do.
Thank you, Lisa. We do have some questions in the chat, and it has to do with insurance. So I believe you've already replied. Your response was whether you do need to have medical insurance or not. The other question has to do with if I have no insurance, how expensive are these tests?
Well, so that there's a range of costs depending on which one you do. So we are offering the stool sample test for free. And if you wanted to try and get a colonoscopy, I think what I would do is I would discuss with you the options for applying for one of the insurance policies to try and get that to be covered for you. And there's two different options for insurance that you could qualify for. I would also suggest that you start with the FIT test if one of those wasn't an option for you. And the FIT test needs to be done every year to be current. Unlike the colonoscopy, which is done every 10 years, the stool sample test is done annually. But I could talk over those details with you. I hope that helps.
Thank you, Lisa.
Mm-hmm.
Should I wait for a screening test at the end of the pandemic?
I can answer that one.
Yeah.
At least for the radiology department, we are fully equipped and ready to welcome patients for screening mammography. We have, safe practices in regard to COVID. In other words, patients who come in are screened. We wear personal protective equipment. The healthcare workers that are within our department are vaccinated. Equipment is cleaned in between each patient. Since the pandemic, we've actually allowed for more time per appointment so that we can do that level of sanitation. And screening mammography is really fast. I mean, the appointment's 20 minutes, but your time in the room getting a mammogram could be like 5 minutes. So yes, it is safe during COVID to have screening mammography done.
I'll address colorectal cancer screening. Obviously, for the stool-based tests, COVID doesn't really affect that at all. It's something you do in the privacy of your home. But as far as the visual tests, such as colonoscopy, most places are testing patients for COVID prior to them scheduling their colonoscopies. There's also a decrease in the number of colonoscopies that are being done so that patients can be properly but medically distant during the procedure itself. And of course, we're checking vaccinations because those would help. Of course, PPE is worn by all the staff and of course by the physician performing the visual procedures.
Thank you, Dr. Leon and Dr. Aguirre. There's a question here. If I have small breasts, is the mammography going to be painful?
No, I think that, whether you have small breasts or large breasts, some people complain about discomfort. It's basically a compression, and it feels like someone pressing the breast, but it's really short. I mean, it's less than 30 seconds that this is happening. Actually, way less than 30 seconds. It's like 15 to 20 seconds. I think that that's something that most people can bear and not have a problem with. And so most of our patients do not report compression as a major problem. There is a minority of patients who, complain that it's uncomfortable, but again, I would stress it's a really short amount of time. You're welcome.
Could you talk about detecting skin cancer?
I'm sorry, I don't understand the question.
How complicated is the process for those who have not had the detection of skin cancer?
Yeah. So as I said earlier, most skin cancers are detected by you, yourself, or your doctor. So if you see something on your skin that's new, that's growing, that's causing you to be concerned, you should mention it to your doctor and they can take a look at it. Keep in mind that most skin cancers are not the deadly kind. They're going to be related to sun exposure, the basal cell, the squamous cell. They're very, very, very treatable. But again, if you, it's not your job to determine what it is. So if you see something new, bring it up to your doctor, and your doctor will decide whether or not you need to see a dedicated skin doctor, a dermatologist. And they have experience looking at skin to see if it's something that needs a biopsy. And if they can't tell just by looking at it, then they'll do a skin biopsy. Welcome.
Thank you, doctor. I don't see any raised hands, but I may see some questions in the chat. So let's keep going. But if anyone has questions, even later, as after the presentation, Lisa Weinbrenner would be your contact. Now we're going to have a survey in the chat. That will be the way that you can register for a bilingual cookbook, a free kit fit, and a free test of your stools that you can do at home. So please take a moment to fill out this survey. Go to the chat section, click. The survey is available in English or in Spanish. We have two different links in the chat. The survey will take you about 2 minutes to respond. And while you're doing that, we'll just give you a few moments to complete the survey. We're also going to show you a page with resources and a page with prevention. Resources also has information about the kits, how you take a stool sample at home, how you access your insurance, how you get to know more about screening for cancer.
Sal, it looks like there's a question about, my Spanish isn't very good, but I think it says, if the mammogram says that you have dense breast tissue or fibroso, is it necessary to do an ultrasound? So in answer to that question, if you're an average risk person, we didn't talk about this, but density is how much tissue there is to fat. If there's a lot of tissue, it makes mammography more difficult to interpret. So in those cases, the ultrasound acts as a supplement to the mammogram. And yes, an ultrasound is recommended in addition to the mammogram.
Thank you, doctor. Thank you for selecting that question. Let me check quickly in the chat to see if we have any more questions. Let's make sure no one's raised their hand. I want to thank everyone for your attention, for coming to this event. If any of the presenters would like to give us any information and last few words.
Thank you, Sal. One other question we received right before we close, if it's okay. What testing do you recommend to screen for ovarian cancer?
Yeah, so again, ovarian cancer is tricky because there's not a consensus guideline for ovarian cancer screening. It's one of those instances that if you have a family history of ovarian cancer, you should speak to your doctor, and they may recommend a screening ultrasound. But again, there's no consensus guideline that says, you know, how many relatives and how frequent. And but a radiology test that could be done would be an ovarian ultrasound. So again, it really just depends on your family history and speaking to your doctor. And also to be aware of your yourself and your symptoms. You know, if you have like a feeling of bloating, or you know your belly feels distended, you might want to know, you know, if there's any fluid there that doesn't belong.
Yeah, I get very similar questions about pancreatic cancer, which is there's no real screening test for that either. But I would agree with everything Dr. Leon said. I have a question for Mr. Martinez, if we have enough time. One of the biggest issues I have sometimes with patients and just people I talk to about colonoscopy is just it sounds like a very invasive test and a very difficult test, especially the bowel prep. I was wondering if he could talk about his experience just briefly with the bowel prep for a colonoscopy and the actual colonoscopy itself.
Yeah, and actually, I'm gonna get my daughter to actually help me with this to answer your question. Louisa, come here real quick. So yeah, it was Dr. Gary. You made a great point. Nobody is looking to call up their doctor, regardless of how great this presentation was, to get a colonoscopy. But this is my daughter, Louisa. Hi. The colonoscopy was part of what found the cancer for me. And one of the hardest things about cancer was telling her that I did have cancer. It was a very emotional and hard time for both of us. Wouldn't you agree? So all of the evasiveness, being uncomfortable, the bowel prep, you have to take a syrup and go to the bathroom all night, and empty your body. Yeah, I'm not going to sugarcoat it. That is not fun. And but the most important thing is your family and yourself, and delaying a stool sample, delaying a colonoscopy is only going to make your fight harder. And it's going to, you know, possibly the fight that loved ones like my daughter, Luisa, have to also endure, because cancer isn't just a one person thing. It affects everyone in your life and your circle that do love you and care about you. So if you are thinking like, colonoscopy is not something I'm really looking forward to, I'll do the stool sample. It is the gold standard, like Dr. Guerre said. And more importantly, I just want to highlight, you're doing it for the ones that you love and yourself, and somebody like my daughter, Luisa. So thank you.
Thank you, Captain Martinez. Thank you for sharing your experience. Once again, thank you, Dr. Aguirre, Dr. Leung, for all of your information. And all of you, thank you for your time, your attention, for being here. And if any of you have more questions after this webinar, please get in touch with Ms. Lisa Weinberger, who is at the Ridley-Tree Cancer Center, who's available for all of your comments or questions. Thank you. Here is the information. Thank you again for being with us, and goodbye.